Good morning, and thank you for the invitation to speak. I'm going to, perhaps a little unfortunately, tell you how much we don't know about adult OI after the childhood use of bisphosphonates. And I will tell you what I think we do know, and that we're working on a transition and adult service at Westmead Hospital for all the people who've finished their childhood care. Obviously, all of you in the audience obviously know.
Excuse me. Can you please speak up louder?
I'm pretty close to the mic. I think it's perhaps dialed down a bit. Maybe I'll try the other one.
About half of us have hearing.
Yes. Is this one any better? Okay. So all of you live with this all the time. Or your family members do, and so I do have a bit of a feeling that I'm bringing coals to Newcastle here, but we'll see how we go. OI varies in between different countries, and the incidence is often unclear because some people, particularly with type 1, can be missed into adulthood, or possibly if they have beneficial gene modifiers, never show up in our OI clinics at all. In the past, so 30, 40 years ago, 85% of people survived their early childhood, meaning that 15% didn't. And the age of bisphosphonates has definitely modified those outcomes, so that the people who now pass away in infancy or before are only the type 2s in most cases. It's because of that we're now getting all of the people transitioning into adult services, and we've become, as the years go by, much more aware that it needs to be more coordinated. It's also sadly well known that if you're 16 to 18 when you finish at the Children's Hospital, it's exactly that time of life when you want to go on and get on and do your own stuff and not enjoy the ambience of the adult hospital. And so people are often lost to care in that transition, and then they may not come back until there's a problem. And obviously it's better to prevent the problem than to treat it after it's already occurred if you get the chance. We don't have data for adults with fractures beyond about 40 or 50 who receive childhood bisphosphonates. So this data is before that age, and it shows the number of fractures per person per year. And the top graph here is the men, and the bottom graph here is the women. And you can see that, as you all know, in childhood, up to 5, up to 10, up to 15, up to 20 years, the fracture risk is much higher. And a lot of that is because your bones are growing and remodelling constantly. And also, of course, children do stuff. So my son doesn't have OI, but he's managed 3 fractures pretending to be Danger Mouse. And the boys on average have higher rates of fractures, possibly because they get out and have more rough play. But you will then note that the fracture risk doesn't go away with older age, and it hangs on at 0.1 to 0.2 fractures per person per year over the rest of the lifespan in these pre-bisphosphonate people. And then we get to menopause for the women, and things really take off in that pre-bisphosphonate era. And by the time women are 25 years past the menopause here in this tall bar, they've got almost a 50% per person fracture risk per year. So this data suggests that as people with OI get older, we will see even more fragility fractures, particularly after menopause. Past, and I'd like to stress that, past, not current, life expectancy with OI did have some limitation, and perhaps that's best shown in a picture here. So at any given age in the white dots, people without OI had a further life expectancy. So if you were 25 back in this data, you would probably make it 55 more years. But if you had OI, there was a decrease there. And it was worse for the people with the more severe forms, so type 3 and type 4. And the colour there shows the difference in the people before the age of bisphosphonates. The main cause of death in those people was respiratory death. So chest infections, respiratory failure. There was also trauma from car accidents and trauma from falling from wheelchairs, and bleeding often related to trauma as well. I'd like to stress again, in case anyone's feeling distressed, that this is the old data and we don't know what's going to happen with the new data. I would like to make the point though that it's better to have a flu vax every year than to get the flu if you're capable of breaking your ribs with coughing. And the same thing, Pneumovax fortunately doesn't have to be had every year, so you can get that and then forget about it for 5 years. But a flu vax every year is a really good idea, even though we would hope that everybody in this room has a better prognosis than that very old data. Now these days, of course, children who are commonly fracturing receive bisphosphonates, as David was talking about, from early in life, and it's usually until they've completed growth or stopped fracturing. The kids have major input from physiotherapy and occupational therapy, an appropriate analgesia, and there's a carefully curated list of surgeons who are used to dealing with bone in OI because it's different to handle during the surgery. We're going to have a talk about dental care later, so I'm not going to cover it. Now, the most recent data I could find is last year, and this chap in Denmark has done his PhD on this topic. Their prevalence of OI was around 10 per 100,000. They have a national health register, so it makes it a bit easier to locate people. He had 687 patients with OI over many years, giving over 25,000 years of person risk. And then he tried to find 5 birthday matched controls per person with OI to look at. And over the period from 1977 to 2013, still including many people who never had bisphosphonates or who only got them in the later part of life, there was an increased risk of mortality with a shortening of lifespan compared to the normal Danish population of about 9 years in women and 7 years in men. But again, that's before the age of bisphosphonates. So this curve shows a life expectancy and risk of, and the green one shows the life expectancy curves in women and men. Now, etidronate came out in 1977 in the US, parmidronate in 1987, risedronate in 1998. So if you were 10, so relatively old to start treatment in 1977, you can still only be 52 now. And it wasn't usual for people to get bisphosphonates back in that age, so nearly everybody who's had childhood bisphosphonates will be under 40. And so this whole bit of the curve here where there is a difference doesn't apply anymore. We're in uncharted territory, and I guess we're boldly heading off into hopefully better outcomes. So now, as I mentioned, you finish your bisphosphonates when your growth is complete and your fracture risk goes down in part because your growth is complete, and then you get too old to see the children's service and come to us. I'm going to touch on the few trials that I could find looking at the therapies that we tend to use in some adults with OI and definitely in some adults who have osteoporosis. So this is the only randomised controlled trial I could find of oral bisphosphonate treatment, and it was in adults with an average age of 36. There were 64 people treated for 3 years, and alendronate, which is also called Fosamax, gave a really good increase in bone mineral density, so a 10% increase at the spine and a 3% increase at the hip. The fractures were not different in this study, and I couldn't extract from the data in the paper how many fractures per year there were. I could only find how many people had fractures. And there was no change in hearing in either group, so the bisphosphonates neither helped nor hindered the hearing. This is the trial that David was referring to about neridronate, which was used to obtain a license to prescribe this for OI in Europe, and they gave intravenous neridronate every 3 months versus no treatment with an open label control. The control group then swapped to the neridronate treatment after 12 months, so everybody got the treatment, just not for the same amount of time. They were roughly the same sort of age as the last trial, and the bone mineral density showed a significant increase at both the spine and the hip. And then the paper concludes that fracture incidence during neridronate was significantly lower than before therapy and compared with controls. But In fact, the clinical fractures on treatment were 1 in the second year of neridronate and 2 in the control group. And none of the controls had a fracture in the second year during which they were receiving neridronate. So in fact, it's 1 versus 2, and of course that's not statistically significant. They actually got their statistical significance by including the 77 patient years worth of treatment before and the 199 years of patient treatment before the neridronate. And of course you are more interested in enrolling in a fracture trial if you've been fracturing. So it makes sense that the people would have had quite a few fractures in the lead up to it. This doesn't prove it doesn't work, but it doesn't prove it does work. And then there's a lot of really nicely written case series and things like that showing changes in bone mineral density in people with OI treated with bisphosphonates. This one used zolendronate, and it was the largest study I could find for zolendronate in OI at only 10 people. Very impressive increase in bone mineral density at the spine of almost 14%, 3.8% at the hip. No one fractured during the study compared to many fractures the year before, but again, that's why patients line up for treatment, because they're having fractures. If we then move on to the nitty-gritty, in Australia it's pretty easy to prescribe bisphosphonates. They're what's called a streamline authority, so you need a special piece of paper. But other than that, you qualify for a bisphosphonate if you have a minimal trauma fracture and no other current osteoporosis therapies. The cost to the government in Australia here is not too bad, and I've shown those numbers there, especially for risedronate. And zolendronate, if you can't tolerate the oral version, is $145 for the yearly dose, but then you have to add the cost of getting the nurse in the IV line and the chair and those sorts of aspects. Now, I'm just going to switch tacks and talk quickly about denosumab and Teraparatide. So denosumab has a different mechanism of action from the bisphosphonates in that it's an antibody to neutralise a thing in your bones called rank ligand, and it helps turn off the cells that eat the bone to allow it to reform all the time. And in people with osteoporosis, it's effective for fracture prevention. But there is almost no data in OI, and particularly not in adults. It looks pretty good in children for an increase in bone density. This report had 10 kids who had previously had bisphosphonates, and then they gave this medicine for every 3 months instead of the adult 6 months. And they got, sorry, that's meant to be a plus 2.2. The Z scores increased at the spine by 2.2% and decreased in the control group. But the paper's a bit funny, it doesn't report hip bone density or any other bone density at all. 4 of the kids sustained a fracture. So all I can tell you about denosumab in children with OI is that it increases bone density. In adults, the data's even less. So this is the biggest case series I found in adults, with a whole 2 adults in it. Patient 3 is the child of patient 2, but I think you'd be reasonably convinced that there's a nice increase in bone mineral density here. It's almost 30% in one person and most of 10% in the other, and also good increases in the hip bone density in those 2 adults. Keep in mind they haven't received bisphosphonate treatment, so this is the treatment naive effect, but at least it's convincingly going in the right direction. Denosumab is faintly more tricky on the pharmaceutical benefit scheme for obtaining, but it shouldn't be a problem for people with osteogenesis imperfecta because the criteria is a fracture due to minimal trauma and no other current PBS subsidised therapy like a bisphosphonate. The downside is that this is an injection, but it's a subcutaneous injection, so it can be done in less than a minute by the practice nurse at your local GP's surgery if you're not keen to learn how to do it yourself. Now, Teraparatide, David's mentioned, and this is an exciting drug for treating osteoporosis because it actually increases bone formation, and at the moment that's really the only thing we've got up our sleeves in terms of achieving that. And this JCI paper looked at 79 adults with OI and randomised them to receive either the Teraparatide or a placebo, so a dummy injection, for 18 months. And 51 of the patients had type 1, 14 had type 3, 12 had type 4 OI, and 1 was uncategorised. Again, nice increases in bone mineral density. The placebo group also went up at the spine, possibly because of the calcium and vitamin D associated with the study, but you can see that the group who were treated with the Teraparatide had a bigger increase. And the hip bone density went up in the Teraparatide group and down in the control group. So that's all very well. Significantly increased bone density, 6% versus 3 and 2% versus -2. But again, there was no significant difference in self-reported fractures. As David has already alluded to, there was not a significant benefit in the type 3 and 4 osteogenesis imperfecta patients in terms of bone density, although the fractures in them, if anything, went in the right direction, so 5 in the control group and 3 in the treatment group. But again, we can't prove that that's effective. Now, the PBS rules for Teraparatide are a paperwork nightmare, but it is possible to obtain it for people who meet these criteria, and sometimes even if your bone density is a little above that T-score of -3, writing to Canberra with a carefully written begging letter. Now, I'm going to try and go through what I think that actually means, since we don't have trials that prove benefit. So bisphosphonates in adults with osteogenesis imperfecta do increase bone mineral density, but there's no convincing proof that they decrease fracture. But there is also no convincing proof that they don't decrease fracture. And in fact, the landmark risedronate study for adults with normal osteoporosis showed a significant reduction in fracture risk from 3.9% to 2.8% with risedronate. Now, if you crunch the numbers, you'll remember from earlier the fracture rates in the years before bisphosphonates were 0.1 to 0.2 per person per year. If you assume that that comes out at 0.15 just because it's the middle number and it's easy to work with, and that you get a decrease of fracture of 40%, which is what they saw in that risedronate study, I've rounded that up to be more in favour of an effect, you'd still need 500 people to prove that the bisphosphonates work for that purpose. So the risedronate study in the adults with osteoporosis included 5,445 women to prove this. It cost the drug company tens of millions of dollars to run. And because bisphosphonates are relatively cheap and therefore they're off patent, they don't make the drug company a lot of money, I think it's fair to bet that there will never be a 600-person study in osteogenesis imperfecta to prove this question. And of course, OI is not postmenopausal or old age osteoporosis. But even so, I think it's very reasonable to consider bisphosphonates in adults with OI who are fracturing, and perhaps if your bone density is now heading south rapidly. No drugs are free of side effects, and I'll get to them in a minute. But about 20% of the people attending our adult service are currently on a bisphosphonate for one reason or another. Denosumab has extremely limited data in adults, and so I think that would be your backup plan rather than your first backup plan. But bisphosphonates are not suitable for people with really poor kidney function, which becomes an issue in many adults as they get older. So it might be reasonable to consider denosumab in people who can't have a bisphosphonate for that reason, and perhaps to consider it in people who responded poorly to bisphosphonates. I chopped out the slides because I was running over time when I practiced this, but there are a few case reports showing really impressive increase in bone density in children with type 3 and 4 OI. So there's the possibility that this might be more appropriate for those people if they haven't responded to bisphosphonates. The downside is that you're stuck with it unless you can chase it with something else, because the FREEDOM study in adult osteoporosis showed that all of the benefit on bone density was gone 18 months after you stop it. So if you start it, you might be stuck on it. So just be prepared for that. I mean, a 6-monthly 1-minute injection is not that bad, but if you start it and then give up and lose all the benefit, it's a bit sad. Now, Teraparatide, your first trick is whether the patient will consider it acceptable, because it is a daily injection, and so you will need to learn to do it yourself or to con a family member into doing it for you. There is also a lifetime maximum of 18 months of it subsidised on the pharmaceutical benefits scheme, although you can apply for written approval in some circumstances. It doesn't appear to work as well on the bone mineral density in type 3 or 4, and it may, and that's a really may, assist in fracture healing in cases of fracture non-union. And so I've been thinking about it as the backup plan for when people have a fracture in a long bone that won't heal. So if your femur won't heal, you can't walk. And I think at that point it becomes very reasonable to consider more extreme therapies like this. I'm just going to cover hearing.
And there's that other, you can use it for 18 months.
Yes, 18 months maximum. And if you exceed that, you can buy it, but it's $480 a month. Hearing. So typically hearing loss is conductive, meaning...
It's not just that isn't that's all you should have in your body?
If you give rodents 50 or 60 times the human dose per day, they have an increase in risk of a really rare tumour called osteosarcoma. And so that's the reason for the limitation. As yet, we have never seen that in a person. And I think if it was going to be a thing, there's been enough Teraparatide chucked around in adults with osteoporosis that we should have seen it. But sooner or later, someone will get an osteosarcoma when they're on Teraparatide, and then we'll all have a collective panic attack. But that is the reason for the 18-month or 24-month restriction.
Sorry. And also, has the specifications for getting it on the PBS changed? Because when I tried to get it, because my primary diagnosis is not osteoporosis, I couldn't get it through the PBS.
I have had to write a 1.5-page begging letter for special consideration, and they approved it for me. Yeah, so I did a fair bit of wrangling with it. I perhaps have a slight inside in that I sat on the PBAC for 4 years, so I know many of the people who would be responsible for approving it. And I stated clearly in those letters that there is in fact a lack of evidence that this will work, but this person will never walk again if we can't get the fracture healed. And so I think it's a very reasonable thing to try, and I've discussed it in very clear terms with the patient that there is no proof that this will work, but that it might improve their chances. So I've got away with it, but it's a paperwork disaster. The criteria I downloaded in the slide were from last week. So they're the current criteria.
And they've changed, yeah.
Yes.
Over 20 years they've changed.
Yes, but that's the last week's iteration. Typically hearing loss is conductive, meaning getting the sound waves through and to stimulate the nerves, and sensory neural in older patients with OI, and that's where some of the nerve cells or the hair cells in the inner ear actually die off, and that's what happens in people without OI to have their hearing. But this study obviously will have been biased to people who had hearing trouble because it's people who had audiometry and answered a survey. So you wouldn't necessarily have audiometry unless your doctor's harassed you or you're having hearing trouble. Here you can see that this is the breakdown of the proportions of OI who had the hearing test, and this is the result. So around half had actually normal hearing, 4.5% had conductive loss, 17% had mixed conductive and sensory neural hearing loss. 15% had been operated on. They don't explain why they excluded this person. They don't explain that, and 2% were completely deaf. Sensory neural hearing loss can be improved with hearing aids. The conductive hearing loss can be improved with surgery, which is why there's such a chunk of people there who have had hearing surgery. Now, you actually hear by your eardrum vibrating with the sound. If you've ever seen a big speaker doing the bass doof doof, your ear does that on a very small scale, and it vibrates 3 tiny little bones in the middle of your ear. And so sometimes hearing loss in OI can be improved by an ear, nose and throat surgeon going in and operating on those bones. Apparently, and I am not an ENT surgeon, this has increased risk of bleeding, so it tends to make the ENT surgeons a little more nervy, but it works very well. It's just that they have to make sure that the bone isn't bleeding afterwards. Now, complications of treatment. This applies to both the first one applies particularly to bisphosphonates. ONJ will be a separate talk later, and I'm going to show a bit of data about the atypical femoral fractures. So you get an acute phase response, particularly after the first dose of bisphosphonates. And if you've had that in childhood, it's done and gone. But then if you've had a number of years off and you restart the bisphosphonate, you can have that fun experience all over again. So bisphosphonates, amongst other mechanisms of action, help to tell some of those bone reabsorbing cells, would you please drop dead? And so some of those cells will undergo programmed cell death, and that probably releases some of their contents which are suitable for eating bone. So you get a flu-like response to that. You can have fevers, definitely aches and pains, headache, runny nose, and it's most prominent with the first dose. It may also be worse if you're vitamin D deficient at the time you have it, but then the treatments work better if you have adequate calcium and vitamin D anyway, so you should fix those first and then have your treatment. Some of the symptoms you'll get relief for simple stuff like paracetamol and Nurofen, so go for it, but just be aware that it's a likely thing. It usually only lasts a few days. Osteonecrosis of the jaw occurs with bisphosphonates and with denosumab treatment for osteoporosis, and occurs quite commonly with high-dose frequent bisphosphonates used for cancer treatment for bone metastases, bone spread of the cancer. So that in a cancer cohort, there's a case series of 327 people that they could find in a few large cancer centres. So it's really not very rare in high-dose cancer treatment. I'm sure there would have been cases of ONJ with osteogenesis imperfecta, but a comprehensive literature review and search last year didn't find any, so that's a meta-analysis paper where they basically had to conclude we're analysing nothing, which is great. But sooner or later it's likely that this will happen in terms of dental surgery, and I think we'll hear about that later this afternoon. But I would consider waiting for major dental work if you're going to have it when you're in a drug-free period. So when you've finished your bisphosphonates, after you've finished growing, give it a year or so and then line up on your dental treatment. Now this is not relevant if you're in pain, just get it fixed. It's also not applicable for people with fear of dentists. It's not an excuse for having normal checkups, cleaning and fillings. We're talking about things like dental extractions, removing your wisdom teeth, having to have a dental implant, jaw surgery, not routine dentistry. There isn't any evidence to prove that holding off the treatment works, but it's based on our thinking around bone turnover and drug effects and how long they take to wear off. So if you're going to be having that period of treatment-free life after the childhood bisphosphonates, it's a great time to get your teeth sorted out. Atypical femoral fractures definitely occur with longer-term bisphosphonates and with denosumab, but I'd like to point out that even with the long-term use, when you're seeing atypical femoral fractures, they remain less common than the normal femur fractures that we are trying to prevent. So it is a problem, but it doesn't mean that the treatment is worthless. Hopefully this will give you some idea of what we're talking about. So A here has the atypical femoral fracture, and it's typically a low trauma injury, but they usually have some degree of pain at the site in the lead up to the fracture, and that's thought to be because you probably have microfractures in there before it snaps through. It's below the fractures that occur with osteoporosis, which are up here in the top of the femur. It's down in the shaft of the femur, and there's sometimes this medial spike, which you can see on the fracture, which is not seen in the osteoporosis fracture. And oddly, the cortex, the white part of the bone on the X-ray here, is often thicker in people who have this fracture than in osteoporosis. So this is a case of a lady who was 75. She'd had 12 years of hormone replacement therapy followed by 3 years of alendronate. You can see that obviously she was on the alendronate for a reason because she'd already done her other femur, but this is a classic atypical femoral fracture after only 3 years of therapy in this lady's case. Another one here, 70-year-old woman, basically every bisphosphonate in existence had been thrown at her over several years of therapy, and she had a classic atypical femoral fracture with non-union, and her case was reported because she then got Teraparatide and the fracture healed quite promptly. So there are at least case reports to back up the idea of using Teraparatide for non-union. This study I thought was very interesting. They looked at 176 people with OI receiving bisphosphonates. It was mostly risedronate or palmidronate, and they had 11 patients out of this 176 who had 16 femoral fractures. And they all happened to be type 3 and type 4 OI, and 10 of the 16 fractures occurred in rotted bones, which are their own whole talk, which will be covered later. But a number of the fractures were not low trauma injuries, and 9 of these 11 patients had had more than 6 years of bisphosphonates. They compared that to a historical control group with the same types of OI who had not been treated with bisphosphonates, and of these 45 people, 26 had 34 femoral fractures, again lots of them in rotted bones. But I'd like you to note there that the much lower rate overall in the bisphosphonate treated group. So even though they had 16 femoral fractures, that's in 176 people versus 34 in only 45 people. And this I think is really interesting. This is that same paper. I've put the 4 people who had these fractures in non-rotted bones as a green star here. And so you can see that there are a lot fewer fractures, obviously, but also I think the pattern has changed here. So I suspect that the treatment probably did decrease femoral fractures very effectively, but it probably also increased those atypical femoral fractures. So what we're trying to do in early adulthood is to give you that period of bisphosphonate-free treatment, which has the very silly name of a drug holiday. It's not something you go to Thailand for. It's just some time off bisphosphonates. They take years to wash out of your bones really fully, and so we're hopeful that in that low fracture period when you've finished your growth, we can get away with a nice clear block of bisphosphonate-free time to decrease the risk of this. But you're still at lower risk, even on the bisphosphonate, than not. There are a number of ongoing trials in adults which will give us some additional information, but it's still probable that they're not going to be big enough to answer the question finally for us. So the Treat OI study is looking at treatment with Teraparatide or zolendronate. So 1/3 of people will have zolendronate for the trial. 1/3 of people will have the Teraparatide, which is artificial PTH, and then 1/3 will have double placebo. And that will be interesting to see how the results pan out over the 2 years of the trial. Sclerostin antibodies are looking very exciting in osteoporosis, but there is very little data in osteogenesis imperfecta. So this one is setrusumab, and they treated 14 adults with OI. 9 received the setrusumab and 5 were the control group, and then they had increasing doses. And it was only a 20-week study, and they looked at bone mineral density at 20 weeks, and there was a 4% increase in the treatment group versus 1%. Unfortunately, some of the sclerostin antibodies are disappearing as the drug companies are withdrawing them from marketing, and this lot have a phase 3 trial listed as active but not recruiting, and it's been 2 years. So I'm thinking they're probably not going to proceed with the larger phase 3 trial. We have a sclerostin antibody that's been TGA approved in Australia now called romosozumab, and you do have to practice these names to get them out. But romosozumab will be obtainable in the country when it's TGA, because it's TGA registered, but it's not yet PBS listed for anything, and certainly not listed for OI. It's an injection, it'll be every 3 or 4 weeks, but it's a subcutaneous injection, not an intravenous treatment. The increases in adults are very exciting, but I think, again, watch this space, and maybe by the time we've been through the bisphosphonates and our backup plan in adults, we may have more data about this. David's mentioned this study already. There is a study actually recruiting right now in the United States where they're looking at the safety of blocking the TGF-beta pathway with fresolimumab. And no data yet, but we will get some data on this in the next couple of years. Pregnancy. Transition clinics need to think about this because pregnancy is a thing when you get into your early adult and adult years. So as was mentioned earlier, if you have OI and an identified mutation, it's possible to have IVF and embryo selection when you want to have children. At Westmead, they will cover the cost of the IVF part for you if you qualify for their IVF program, which basically means you have to be a non-smoker and things like that. And you have to have a body mass under 150 kilos because the table won't hold more than that. And so that's a non-negotiable thing because the table just doesn't hold the weight. Then you would only have to pay for the genetic test itself, which is around the $1,500 mark for all of the embryos, not per embryo. But if you have to have a later cycle and another later fertilisation, you'd be up for the $1,500 again. But you would be unlucky not to get one really good embryo, and most people would actually get 2 or 3. And then you don't have a fertility problem, you wouldn't be having the IVF for a fertility problem, so each cycle of IVF has a better chance of successful outcome when you have it. IVF's not fun, it's a hormone-induced roller coaster, and then the pregnancy question is another emotional roller coaster, so you have to be prepared for all of that, but it does work. Bisphosphonates are not safe in pregnancy in most cases. And denosumab is not safe in pregnancy unless there's a really good reason for it. In both cases, it's a bit like the Teraparatide. If you give 50 times the dose for an unreasonable amount of time, you can cause problems in animals. We don't have documented problems in people, but you'd avoid it if there was any possible way to avoid it. So what we want our transition service to do is to coordinate care. If you're seeing a lot of different people, we would prescribe the bisphosphonates and so on if they're needed for you. I tend to rant about calcium and vitamin D because a lot of you spend a lot of time working indoors and not getting outside. So you would be like the endocrine department at Westmead. We all tested our vitamin D about 10 years ago and one of us was normal, and it wasn't me. So you need vitamin D to absorb the calcium, you need vitamin D to keep the calcium in your body, and then obviously you need to eat the calcium either as tablets or preferably in your diet. Then we talk about sensible exercise and what you can do based on whatever's happened to you in the past, which is not going to hurt you and will actually be helpful. And I try, but don't always succeed in trying to figure out some form of exercise that will be enjoyable to you, which is a separate question. I coordinate referring to physios and occupational therapists. We refer to the carefully selected surgeons. They're not all in the same hospital, so it's better in that circumstance to travel across Sydney to a surgeon with expertise. We do hearing testing at intervals, which get longer if the hearing is okay, and we always discuss pregnancy planning issues. I'm really excited though that we're moving to IAM next year when the adult and young adolescent medicine new outpatient area opens. It's the same hospital, but it's going to be a much nicer area set up for teenagers and young adults. And so it has less of that sort of adult hospital ick factor. And the plan is and the hope is to have ready access to most of the allied health services in the same area. So Westmead is huge, and making the distances across the hospital can be pretty tiring. And because more than half of the people I see for OI are currently under 30, they've said I can just move my whole clinic lock, stock and barrel, so you don't have to be under 30 or in fact an adolescent or young adult to get in there. And we would accept adult referrals once you've finished your child care, and we bulk bill people for any genetic bone disorders. So thank you again for the invitation to talk, and to Prof Salentz who did that, and Craig Munns who I went through university with, and Andrew Biggin down at the Children's Hospital. I have no relevant conflicts of interest, so I don't make money from any of those drug companies or those drugs that I mentioned. And if you'd like to inquire about an appointment, I've put my receptionist's phone number up there. Thank you.
Does anyone have any questions? Gunton?
Just a question on calcium and vitamin D supplements. Is there any evidence to suggest it increases the chance of kidney stones?
If your vitamin D is low, you have increased urine loss of calcium. So yes, in that situation it may. And then if you're taking excessive amounts of calcium, you could also increase your urine calcium loss. if you're worried about that because you've got a personal or family history, the best thing is to drink a lot of non-alcoholic fluid. Calcium is not very soluble, so you need bigger volumes of urine to dissolve more of it. And yeah, but it's a good question. And we do obviously see kidney stones in the older people with osteoporosis, a reasonable amount. If anything, you'll have a decrease with the therapies.
Is there an actual level of vitamin D that you recommend, like on the scale?
Yes, so over 50, so we take the lower limit as calling deficient, which is 50. So we would like it to be over 50, and in a perfect world, we would like it to be over 75.
Why don't you say about 100?
Yeah, so your body has this feedback loop where your parathyroid glands get activated to produce parathyroid hormone when your body thinks you don't have enough calcium. And the parathyroid hormone gets to the bottom of its curve around 75 or 80. So 100's great, because then you can forget your tablets for a day or two and you're not going to end up low. But 75, 100, 125, all great. Yeah.
Can people that are not in New South Wales access the Westmead Hospital?
I have difficulty with our money crunches if I want to admit people for anything, but if you want to come and see outpatients, I can squeak that through the system.
Right.
Sharina?
Is it safe to go see an average physiotherapist?
I wouldn't recommend it, unless when you meet them they seem to have a more than common dose of common sense. And in fact, we're trying to get the Children's Hospital physios to do some training of our adult hospital physios, so some more formal training so that they know all the things that Verity's spent her PhD describing as being really good for therapy. But if they're actually listening to you, and they really go and have a think about it, I think they should be all right. But as a general statement, it's like the surgeons, better to travel a bit further to someone who knows what they're doing.
Sorry, just touching on something that you mentioned then about people having atypical fractures in femurs in older women after bisphosphonate treatment. Made me think of something that we do naturally as a family in terms of managing our child's OI that I don't know whether other people do or not, but you said that they had pain before they broke, and we have heard many adult OIs say the same thing, and certainly it's the experience in our family that something hurts in a particular spot and then it breaks.
Yes.
And so when that hurt happens, we know it's not going to show up on an X-ray. We know if we go into hospital, they'll say, there's no break there, it's fine, go off and run and play and it'll be fine. We know that if she runs off and plays, that it will then break later in the day and it will be something much more traumatic and could require surgery. So we don't put a cast on that, but we do rest that. So our child is in a wheelchair at the moment because she has one of those pains in her femur, and it wouldn't show up on an X-ray. It does start to cause a bowing of her femur, and the more it bows, the more it cracks, the more it bows, and then there will be a catastrophic fracture. However, if we rest that until it stops hurting, it will stop hurting without having had to go through the casting situation, without having to go through much more pain, and then she gets on with life, and that's a really relatively quick and easy way of minimising her fracture rate.
I think that sounds very sensible. You just want to balance up the loss of muscle mass that can occur if she's not doing anything. Yes. So if it doesn't cause her any discomfort to do simple sitting down leg exercises minus her body weight, kids recover quite quickly. But if you were to theoretically get to adulthood with very poor muscle mass, it's all downhill from 25 in terms of your muscle mass. But obviously you'll lose more muscle mass if you break it and have it in a splint for ages.
For a much longer period
Yes, and I would just make sure that your vitamin D is normal and try to encourage calcium intake. People with OI in adulthood tend to fall into two camps, one which is like dairy is yummy and the other is the yogurt face. So you ask them if they like their dairy and cheese, milk and yogurt, and you say the word yogurt and they go, I think when I've asked them about it, most of those people have been force-fed dairy products as a kid and rebel as adults and absolutely hate it. But good calcium intake, good vitamin D and sensible avoiding extra trauma. You can, in some cases, get a look at those early fractures with a really zoomed in x-ray. If they've got a high definition x-ray machine, you can see just the periosteal layer is looking a bit odd. But you won't see it on a normal x-ray where the whole x-ray is like this big on a screen. You have to be able to zoom in and have a close look. And I took out the slide about radiation exposure, but the majority of radiation exposure in people with OI occurs from CAT scans and bone scans. So while you sometimes need to do them, they are to be avoided if they're not needed because of the radiation exposure.
Essentially, sorry, go on.
I broke my femur, which had a rod in it 2 years ago, and was told it would take 3 years to heal. But the fact that I already had the rod in it, they took the rod out and re-rodded it longer. It's so that's holding it in place. So if it's still a non-union, it doesn't matter because I can still exercise because the rod's there to protect.
It helps, but you can still manage. Yeah, it is still possible to manage significant fractures in the presence of a rod. So it has to be same story done with common sense. And the rodded fractures are a different clinical question, especially for the orthopaedic surgeons, from the unrodded ones.
Because of arthritis, and I have no pain, no gain. I don't feel any pain when I break.
Very tough.
We might. Sorry, I do have one.
Last one?
Yeah, it's more of a discussion. I'm curious. I actually took the Protea injections for a couple of years, and because you said there's not enough evidence on it, I wondered if anyone in the room has had those injections as well. You have?
I'm just
Okay, so there's quite a few of us.
Yes, I mean it's a reasonable thing to consider. It's just there's not much in the literature. And so, I mean, if you all got together, you could probably find your own bone mineral densities from a couple of years ago, and then you can look at the post ones and see how it's going. Oh, I've got to get on a plane.
Savina was trying to bring it
Oh,
up.
ONJ, so there's been data.
Yeah, I figured it's just not in the literature, and people will be going, yes, these drugs, we know they do it, but at least it doesn't seem to be really increased. So the cancer people get really terrible ONJ, and compared to normal bisphosphonates use, it doesn't seem worse.
Thank you very much.
Thank you.
Photos.
Could I get... Are you going home, David? Are you going home later?